All right, good. Because I was born and raised in the Philippines, and tell you the truth, the Filipino language is twice as faster as the English language. So I have to remind myself to speak slowly, and sometimes I do get carried away. If that happens, just switch on the subtitle and something will come out on the screen. So again, Tammy, Dr. Aiken, thank you for inviting me to speak here because we started this program together. So as somebody who has this profound sense of duty to teach and mentor nurses, I'm excited to tell you a story today. And it's about how a small rural hospital that we were able to develop our own onboarding program for new graduate nurses starting in the ED. So for the past 2 years, I don't have any financial ties with any company whose products might be relevant to this presentation. I wish I have, but no, that would be nice, but I don't. So I work at Bassett. I joined the organization 3 years ago as a bedside nurse, and then I transitioned to becoming their educator. The hospital has been around since the 1900s, and it has become a great healthcare system across central New York with 6 regional hospitals and a number of healthcare centers. And so I was hired at the main hub, which is Bassett Medical Center. It's located in Cooperstown, beautiful town. Excellent, we fell in love with it. And I'm so happy to announce, because as of last week, we are a magnet hospital. So that deserves a round of applause. So my objectives for today is that we will be able to reflect on the challenges, what we faced when we were developing this program. We would also look at the key strategies that we implemented, the lessons that we learned, and the principles that we followed. But the real dream is that every emergency department or facility will adopt or develop their own onboarding program for new graduate nurses. So let's dive into the challenges, what we faced. Shocker, right? Limited staffing and resources. Most rural nurses would say they have greater patient-to-case ratio compared to their counterpart urban nurses, and they often say that they have fewer resources. ENA says, and staffing has always been a massive issue with emergency room nurses. ENA says that 1 out of 5 emergency room nurses quit or leaves the profession within their first year. Right? And the second year, 1/3 of them leaves the profession. So you might ask me, Ralph, what does this have to do with starting your onboarding program? Well, for one thing is you're gonna put a lot of strain on your preceptors because you're running out of it. Second, and my worst fear, is that in order to balance the staffing sheet, managers will be forced upon to sign off or release their new graduate nurses to their orientation. Financial crisis, financial instability. Did you know that 700 hospitals across rural America is at risk of closing? That's over 30% of rural hospitals in entire America. Unfortunately, we were one of those 700 hospitals. Last year, we learned that we have a significant debt, and then it was necessary to have a major realignment. And that happened in the middle of the program, of the onboarding program. So imagine the morale. And now I have to work with whatever resources we have. Personal isolation. So as a network of hospitals, communication and implementation projects can be challenging because we have different priorities. This is not the first organization that I work with multiple facilities. And oftentimes, allocation of resources can be perceived as unfair or can have a sense of depravity. Geographic location is also a significant challenge among rural nurses because they have limited resources. I learned from one of our new graduate nurses that they don't have a respiratory therapist 24/7. So what that means is that they have to learn how to manipulate and troubleshoot mechanical ventilators. Oftentimes, they work in a small group, meaning they have limited access to specialists, mentorships, and skills development can be challenging as well. On top of that, in relation to limited resources and manpower, rural nurses are frequently taking wide range of roles. So as Dr. Aiken said, I have 15 years of experience as a nurse. Cumulatively, I'm an educator for 5 years. And I'm in this unique position as a mediator between the frontline nurses and the leaders, the managers, and some of the educators. So they come to me to verbalize their frustrations. Most of the senior managers and the senior clinical educators would complain about these new graduate nurses, how they are quote-unquote soft, comparing to their training 30 years ago, how they were trained, that they were thrown into the wolves, right? And now reflecting back to my experience 15 years ago, I don't want to go back there. No, and I refuse to have that culture. If you look into these generational categories, most of your new graduate nurses will fall into the Generation Z. How many Gen Z's nurses we have here? Oh, just a few. Okay, others are shy. You should, raise your hands. Interestingly, there are 2 studies that came out recently, one in 2024, and the other one was in 2022. So what does those studies say? Those studies said that Generational Z new graduate nurses in a standardized group training are often or at higher risk for pressure crisis, that they are not exposed to acute and critical cases, that they lack professional rich physical quality training and experience. And that's because of COVID-19, where a lot of face-to-face classes has transformed into virtual classes. And we know that there are pros and cons of attending virtual classes. Furthermore, the studies, they said that Gen Z new graduate nurses are often and highly affected by roles, responsibility, knowledge, and they often have experiences of doubt and role confusion. That work disorder adjustment is what we call transition shock. So if you are a nurse educator, a manager, a leader, and if you're implementing the same strategies that you have been implementing 30 or 20 years ago, you better sit down and think about it. So when last year, when Dr. Aiken told me that, Ralph, we just hired 7 new graduate nurses in the ED, okay, across the network. And she asked me, what are we going to do to make sure that we support them and make them, good nurses? And I told Dr. Aiken, Tammy, don't worry about it. I got your back. I'm going to develop and create the best onboarding program that you'll ever see. Tammy's faces. You didn't say that. Well, those were not exactly my words, but it's in the same line, falls in the same line. It sounded more heroic. But, I told her that we need a foundational program for these ED nurses. And it's nothing new. It didn't came from my brainchild. I definitely did not invent the onboarding program. As a matter of fact, ENA has an extensive residency program for new graduate nurses. Our organization has an onboarding program that's been going on for years. However, and historically, when we hire new graduate nurses, they would end up in medical surgical floors, right? Thinking that it's better for them to start on the floors and then think about moving to a specialized area. In the recent years, we see a trend. We're getting more and more new graduate nurses entering the specialized units, like the ICU, labor and delivery, OR, and of course the ED. So now, given all those circumstances that we face, those challenges that we face, my mission was to develop our own onboarding program for new graduate nurses in the ED. And if you are in the same situation as I am, where do you start? So where did we start? Well, you start by looking at the components of an effective onboarding process. The first thing you need to do is you need to have a structured orientation program, hence the birth of our ED Bootcamp. Why did you entitle it the ED Bootcamp? Why not? I was not a fan of that title, but that's what the team came up with. Start by conducting your learning needs, right? Talk to your senior nurses. If you had new graduate nurses to prior year, speak to them. Let them ask them about their experiences. When you are designing your curriculum, look into traditional versus concept-based education. So our ED Bootcamp is a mix of traditional. Traditional meaning you have a lecturer. It's a lecturer-led classroom setup. Concept-based is, that would be your simulations, case studies, article reviews, where you let your participants or your students or your nurses lead the discussion. So we mix those both because it's important that you cover various learning strategies and learning needs. Simulations was a big hit for us in the ED Bootcamp because there was a major gap in knowledge and practice. These nurses that are coming in, they're very knowledgeable because resources now are easy to grasp. Do you remember those days where you have to go to the library and find the resource that you need? Now they don't have to do that. I'm not sure if our library doesn't exist anymore, right? So when you're conducting simulations, take note that nobody wants to be put on the spot, right? Senior nurses, new nurses, nobody wants to be put on the spot. So it's important you have a very constructive pre-briefing. Look at the elements of what a pre-briefing is. The way we did our simulation is, they put me on the spot first. So I was given a scenario that I have no idea what was the scenario. So I did the scenario. We taught them how to do the nursing process. They have to assess A, B, C, D, and E. Whatever the situation is or whatever the case of the patient is, they have to do the A, B, C, D, E. They have to follow those steps. So they put me on the spot, and they criticized me. And of course, I made a lot of mistakes, right? And that's okay. That's what we wanted. We wanted to show them that this is a simulation, this is a psychological safe environment, and it's okay to make mistakes. Oh, by the way, that was intentional that I made mistakes. As part of the ED Bootcamp, we also send them to different specialized units like the ICU. So they stayed there for a couple of weeks, ICU, step-down care unit, cath lab, and labor and delivery. Organizational support is crucial. Now, having a positive organizational culture does not happen overnight. I certainly did not create a positive, it wasn't because of me, that's why we have a positive organizational culture. But you can start somewhere, right? If you are a nurse educator or a manager, you can start somewhere. Start small. Start by welcoming your new graduate nurses. How do you introduce them? How do you introduce them to the rest of the team, to the providers? Do you spend time with them to get to know them, have coffee with them? I keep tabs, by the way. And obtain leadership buy-in. I was so blessed that I didn't have to create a very convincing elevator pitch because Dr. Aiken had my back, and the managers as well. They were all bought in when I brought them up the idea of the onboarding process. Preceptorship and mentorship is an integral part of your orientation program because they are the ones who spend a lot of time with your new graduate nurses. But it has to be with careful selection and evaluation. How do you select your preceptors? Are you involved in selecting the preceptors? Our education team had a brilliant idea on how to evaluate them. Is we gave them QR codes. So every now and then they scan those QR codes, and that will lead them to a survey so they can evaluate their preceptors. One of the ways I do to effectively evaluate if they're learning from their preceptors is I do frequent check-ins. I check in with them every now and then. What I learned from my father-in-law is from my dad-in-law, is the 70-20-10 rule. So what does that mean? It means that 70% of the time, if you're a trainer, you have to be with them. So as much as possible, I try to be out there, be with the new graduate nurses. individualized learning need. When you check in with them, try to identify their strengths and their weaknesses. Two of our new graduate nurses were very keen in ultrasound, in inserting peripheral IV, ultrasound-guided peripheral IVs. And it wasn't part of our onboarding program. No, I've never imagined that new graduate nurses would be able to learn that, because as an ER nurse, that's one of our pride, right? That's one of our measures if you are a good ER nurse, because you can put in an IV on a pediatric patient or on a difficult stick. But two of our new graduate nurses became really good at ultrasound IVs. And it gives me pride. It makes me happy, because senior nurses are asking for their help. They get called up to ICU to put up an IV, right? New graduate nurses. And of course, emotional and psychological support. You need to acknowledge that working in the ED can be overwhelming, can be stressful. You have to make sure that they would learn how to direct those stress and manage those stress. You have to let them know that it's okay. It's okay not to be okay. We do have an open door policy. Mentorship also plays a big role in this, because a lot of people, a lot of trainers didn't fully grasp what mentorship is. Mentorship is more of a relationship. You have to develop that relationship to your preceptor or to your orientee, and allow them to express, if they're frustrated, if they're having a difficult time. All right. So once you've done all your research, once you've developed your curriculum, how did we implement that? What strategies did we use to make this program successful? First is you identify your resources. We invited guest lecturers with profound experience in their specialty areas. I started with my senior nurses. It's a good thing, because I started at the bedside. I can identify senior nurses who has this ability to teach, the passion to mentor and educate nurses. I started with that. Then I befriended a cardiothoracic nurse practitioner. So despite his busy schedule, he was able to come down and teach EKG readings. I was able to invite the chief of our pediatric department, Dr. Green, and so you can see the diversity, and then they can teach with experience, not just with theory, but they'll be able to tell stories of their experiences, and that bridges the gap between your senior nurses and your providers as well. ENA modules has been an integral part as well. ENA modules, if you don't have it, I recommend that you look into it. These are online, self-paced virtual learning that gives, that can streamline your education. You will have one language. So what we did is we would ask them to complete certain ENA modules before they attend the class. AI, leverage on AI. We are in a world of AI. I hope you all agree with that. There's no going back. And I highly recommend that you start looking at AI, because it drives productivity, and it helped us really when we designed our program. Do you like my presentation? Do you like how the graphics, the pictures were put in there? That's AI. So Canva, start with that. If you present a lot, if you teach, if you are a clinical educator, a public speaker, look into Canva. So Canva is a user-friendly, versatile AI application that's good with graphic designs. It can also create AI images for you. So if you cannot find what you're looking for, you can type in a few words and it will generate AI images and videos as well. So gone are the days where you have to go to a web page, screenshot a picture, and then place that on your, it's basically stealing, right? So gone are those days, because you can use Canva. Large language models, that will be your Copilot and your ChatGPT, okay? If your company is subscribed to Microsoft 360, then you have Copilot. So large language models are highly advanced AI that responds to text. They can absorb and generate text like you're speaking to a human being, right? They're very good with answering questions, translating languages, and you can also use that in summarizing your content, as well as creating graphic designs as well. I use Copilot a lot. As what I said, I was born and raised in the Philippines, so English is not my first language. And sometimes when I write emails, I get misinterpreted. So I use Copilot to check my grammar, to check my tone. And I also found that using these large language models as better search engines compared to Google. When you're creating your curriculum, when you're trying to find resources, try to use large language models, and it can get you it can find you what you're exactly looking for. The key with large language models is an effective prompt. So it will depend on the words that you're typing in there. So that's what you have to learn. I was creating a triage curriculum, and 15 years of experience as a nurse in the ED. So I need 20 questions. I need 20 triage questions, ESI. So I'm like, it's gonna be a piece of cake. I can make 20 scenarios just like that. 3 hours have passed, and I only had 2 scenarios. So I went to, I wasn't sure if these large language models can help me with it. I wasn't sure. Like what I said, I'm not an expert. I'm still trying to learn this large language model. So I started with, hey, if you were to create a triage curriculum, what would be the content of your course? So, blah, 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 blah. Would you be able to learn and summarize for me the Emergency Severity Index version 5? So it did. And then so it really depends on what you ask AI. And then my third question was, can you give me 50 ESI level 1 scenarios, including their vital signs, and make sure that the temperature is both in Celsius and in Fahrenheit, and please don't forget to include the pain scale. In less than a minute, I got 50 ESI level 1 questions. Jane AI. Jane AI is one of the tools that we use. It's embedded in our health stream. So Jane AI helps us to identify individualized learning needs and assessment. Our new graduate nurses will receive, I'm not sure, how do you often receive the Jane AI? Biannually? So they would receive it at first. They would be given scenarios and questions, and you can identify there which part of assessment or critical thinking that they're lacking at. They also receive confidence survey. And speaking of survey, there was a survey that was sent to 700 business leaders about what do they want their employees to have now that AI becomes more prevalent. And do you know what their answer was? Virtue, integrity, and strong moral character. But wait a second. A while ago, you were asking us to leverage on AI. Now you're saying us that this is what most employees are looking for. Well, you see, despite that AI is becoming more and more prevalent, most employers would value soft skills. Soft skills are becoming more valuable than ever. Because if there's one thing that AI cannot do, it's to build human relationship. And that's an important key strategy when you're developing and implementing this program, because you cannot do it alone. You have to create an atmosphere of collaboration. I have seen brilliant people who cannot get the job done because they don't know how to socialize. They don't know how to communicate with their leadership. So clear communication with your stakeholders, you have to identify them and you have to keep them updated. With ED managers, you have to accept that there can be some tension. You have to assure them that it will not affect their operational demands. Build a team. Any evidence-based practice will say that you have to build a team. Remember the first team that I had didn't work? Yeah, so when this idea came out, the ICU clinical nurse educator also approached me because they have the same idea. And we thought that it would be excellent if we combine ourselves together. And ER, ICU, didn't work at all. Not at all. So I went to Dr. Aiken and I asked her, because I was new at the organization. I don't know anybody except for the people that I usually work with. So we scoured the whole facility, the whole network, and identify people who can help me. Identify people that has the same passion that would be committed to this onboarding program. So collaborate. It doesn't have to be a competition. I'm an introvert, so speaking in public, I hate it. Being a nurse educator, my manager, the nursing education manager, told me in one of her introduction speeches, is that our job is mostly, you need to have good social skills. And I'm an introvert. My wife can testify to that. I hate confrontation. So when I come home from a basketball game or from jogging and the dishes hasn't been cleaned, it's a code gray. It's a code gray. And I would naturally run to my man cave, because I don't like confrontation. So I would hide in my man cave. Not because I'm afraid. Not because I'm afraid, but I don't like confrontation at all. Oh, Ivan, you have to cut the record. You have to cut that part in the recording. Yeah. So my social skills needs refinement. It needs pruning. And I can be a little bit awkward at first when you get to know me. My wife will tell you that I can come off awkward and weird, and I can be a nerd sometimes. So like what any introverts did was I read a book. I read a book about Winning People by John Maxwell. So Winning with People by John Maxwell, he shared a lot of different principles on how to be a good social communicator. And there was one principle that really stood out for me, and that's the 1% rule. Have you all heard the story of Seabiscuit? Yes? Can you tell me? No, I'm kidding. So Seabiscuit, legendary racehorse, his story was amazing because it's a story that embodies resilience, perseverance, the triumph of the underdog. It happened in the 1930s during the depths of the Great Depression, where this scrappy, small, unassuming racehorse has captured the imagination and the love of every people because historically, he's the most winningest horse in the entire world. And that's because of the team that he had. His trainer, Tom Smith, they called him Silent Tom because he's a man of few words. His jockey, the one who rode him, Red Pollard, was at that time partially blind. And then his owner, Charles Howard, was a rich automobile businessman who knew nothing about horses. But they have one thing in common. They wanted to win. So what is this 1% rule? 1% rule is finding a common ground with others, even if it's just 1% of shared values and interests. By nurturing even a small area of agreement, you can build stronger relationships, foster collaboration, and enhance communication and teamwork. If there's something that I want you to take away from this presentation, it's the 1% rule. So the onboarding program will not be successful without my team. So I really want to give credit to them. So Barbara Euler works at Cobleskill Regional Hospital. She covers the education at that facility. Miranda Darling, also a clinical nurse educator from AO Fox. And Emily Sitterly, who's here with us today. She's actually one of our senior nurses, but covers a lot of the education program as well. Kerry Johnson, my manager, who ran the simulation with me, and Julie Falcone has been leading our residency and onboarding program for new graduate nurses. These are some of our pictures, as you can see here. We invited our nurse leaders to be part of those programs. So I had Dr. Tammy Aiken open up the boot camp. I also had our CNO, Dr. Angela Belmont, to have a table talk discussion with our nurses. This is a sample of our simulations where one of our midwives demonstrated how to an imminent childbirth in the ED. And those are our nurse residents. We have 7 of them. You know, we believe in them so much, we invested on them so much that we dragged them here. And so they're all here, sitting up in front. So they're here, they're having a great time. So network with them, talk to them, but don't recruit them, please. Last key strategy is to sustain it. Every evidence-based model will tell you that you have to celebrate the launch and you celebrate the success. Disseminate the results. Talk to a conference, speak at a conference. Keep the conversation ongoing because you want to sustain this. No matter what, even though I told the ED managers, even if we only have 1 nurse resident for the year, we are still going to proceed with the program. Advertise it, market it, social media. I learned this the hard way. We had a summer nurse intern who was very good, and I met her one day. I run into her and I asked her, did you apply as a nurse in the ED? And she said, no, I applied to this hospital. And I was curious, so why is that? That's because they have this program where they teach you how to become an ED nurse. They send you to the ICU, they send you this and that. And I was like, we have that. Now, I might have painted a beautiful picture of the boot camp. And, it's far from being perfect, really. We learned a lot. Learned a lot of our mistakes, and we are revamping it for this year. And it will only be justified if our nurse residents will tell you how they felt when they started their career in the ED, what were their experiences, what would help them, and what the ED bootcamp meant for them.
What made me want to get in the ER was my previous experience prior to working here as a nurse. I worked here in the ER for a number of years as a tech and always really enjoyed that. And prior to that, I was in EMS working on the ambulance.
Honestly, I don't want to say just because I like to help people, but it is such a rewarding feeling, at the end of the day, coming to work and helping people that are sick, and it is just rewarding.
And I mean, I've worked with a lot of nurses over the years, and all of them told me that I was meant for an ER in some way. I don't know. They all just saw it, and I said, you know what, maybe, and it's working out well.
The fast-paced environment and how you never really knew what was going to come through the door. So I think that's what drew me originally to the ER.
Like you said, you hear a lot of older nurses, like when you say, hey, I'm an ED and I'm a new grad, they're like, oh, like you just jumped into the ED, like that's bold, I wouldn't do that. Like that's, especially here in kind of a smaller ER when you don't see as much as the bigger ones do. It was kind of scary. Everyone was saying like, oh, we don't see as much, you're not going to get as much experience, and you can be kind of on your own sometimes.
I graduated when I was 21, so I was just legally able to drink, and now I'm in charge of everyone's lives. It was a little scary, honestly.
Starting as a brand new nurse down here, I was terrified. I'm like, oh my gosh, what do you mean random things are coming in? And I have no idea. I knew that that's what the ER was going to be, but I was still nervous to see it firsthand.
I do think that it is a good idea to have maybe a year or more of experience in a regular medical setting first, because it's a lot. It's a lot of responsibility to come into a critical atmosphere.
As far as the classes go, the residency with Julie really, I feel like, prepared me more emotionally. They make some very in-depth scenarios that really make you think about how you would answer in real life.
So they'll have you talk, you'll go through a lesson, and then you go and do a sim lab. So one of them was dealing with family members that may not be the nicest. which if you haven't worked in healthcare before, that can be like a huge struggle going up to somebody and they're like screaming at you because you're supposed to be responsible for their loved one.
We did a lot of like patient scenarios, and we talked about our experiences working in the emergency room so far, which was super nice.
The boot camp, the ED boot camp, was a great experience, getting us all together, us new grads in the ED setting, and introducing us and educating us on various things that we would see.
I liked boot camp. I did. And like I said, it was just good to kind of like touch base on things that like I hadn't thought about, you know what I mean, in a while, or like, oh yeah, I remember this, you know, just as refreshers. So it was still good.
I loved the simulations in ER residency, really being hands-on, and you guys really made it set up with the beeping noises and everything, make it feel really realistic. I wish that we could like have respiratory therapy, new people come in too, and make a scenario where we're all there. But yeah, so that was super helpful.
I always get nervous doing the simulations, but you know, at the end of the day, they're super helpful. And of course, it's nice watching everyone else do it, because I think, you know, we both watching other people do it and then them watching you do it, you can all come together and be like, oh, well, I'll remember this next time.
So in my personal opinion, I felt that the ER boot camp did teach me more because it was targeted directly at my practice. And that's why I said I just wish that I had a little bit more time so I could tune in and have focused on that. Because I feel like the tools and the resources were beneficial to what I'm going to be doing daily.
The most like useful or helpful to me was definitely like the rotations, especially being in ICU. Like, even though it was only for a couple weeks, I felt way more comfortable with titrations and drips and a lot of other things that we still see. But it was a constant thing up there. So that was very useful.
I remember I had this mother who came in, you know, she had some vaginal bleeding. I wasn't expecting to deliver that day, but, you know, the midwife said, yeah, we're going to have this baby right now. And I remember working with her and the labor and delivery nurse really closely during the delivery. Towards the end, it was just me and the nurse, and the mother said, oh, I feel the baby coming. So we jumped into action, you know, like the baby came as it does. And just, I felt like in that moment, just being able to be there, learn with someone who does that specialty, I just like, it felt more close to home and like I could do it.
The staff themselves, the educators, both for the residency and the boot camp, were both very helpful in being readily accessible to reach out. You know, especially you were readily accessible if I needed to talk about either a tough day or a medical situation that I think I should have handled differently, and then we talked through it afterward. Advice on IV ultrasound skills.
The most important part is just having the support to get you through it. Again, being in a high-paced environment is like super scary at times, especially if you really don't know much about the emergency room.
I feel more comfortable. And like I had a patient yesterday that was more on the critical side. And yeah, I just felt more at ease with it, just because like you get exposed to more critical patients, and that's all you have up there. So you just get comfortable, you know, and just like seeing what you're going to see and like stuff that you're going to have to do, and documentation wise too. You know, I felt like it definitely helped me.
But it's all been very great, that's for sure. I think if I had come into it initially without any of the extra stuff, I would have had a tough time continuing through with it. I think I would have felt the need to step down to a different floor for a while and then come back.
30% of new graduate nurses leave within their first year of hire. More than half quits on the second year of hire. Now let's see where Bassett stands. We had a 23% turnover rate of new graduate nurses from 2021 to 2023. It cost us around $1.3 million. Onboarding programs, they say, you know, if you create an onboarding program, it can reduce your turnover rate to 10 to 20%. We're not far off from the 30%, so we have to do better. Some robust onboarding program claims that they can reduce turnovers from 5% to 10%. Onboarding programs is more than just an introduction. It fosters competence, resilience, and confidence among our new graduate nurses, especially in a high-paced, high-stressful environment. It doesn't just ensure the success of the individual nurse, but the entirety of the emergency team. Thank you very much.